I'd like to thank again for the organizer to invite me and many of my colleagues here. So exciting to see the science, but more enjoyable to see the friends. So today I want to talk a little bit about basic neuroscience model, but also try to see how much clinical relevance we can come from those kind of approach, especially nowadays we're talking about AI. And let's back to some basic. So the white matter, we all know it's like a computer motherboard rather than CPU. And then the myelinated axons, and in brain there's some unmyelinated or partially myelinated axons. And then integrity is so important, certainly in the MS, we know is a white matter problem. But in the mental illness, I think there's a lot of potential to look into it, rather than neural receptors and transmitters. Here's a type of neuroimaging technique. We just mentioned DTI and MRI and functional MRI. And a lot of time we visualization, quantification of white matter structure and function, not only neurotransmitter like PET scanning. So here you can see diffusion spectrum MRI. There's really follow the neuronal track, all the connections, different region connections, coordinations. So mapping human connectons, a lot of work that talk about the structure connections, talk about the function connections, and also temporal connections. So when we talk about a connection, there are so many different kind of concept and approach. Molecular imaging, chemical connections, and receptor distributions, and different kind of approach. But also there's invasive and non-invasive mapping, such like EEG with white matters. So disruption in white matter integrity normally will reflect some EEG changes. And also EEG is waveforms correspondent to distinct brain state and activities. So we focus so much expensive research all those years with MRI. But right now with AI and more technology, computer power, I just wondering if we can go back to the old data of EEG to figure out something reflect brain function, especially global brain function. So there's significant clinical implications when we look at white matter. Longitudinal studies and dynamic interplay between white matter changes. EEG measure over the course of antipsychotic illness and its treatment. So the people always talking about hyper-connected brain, especially study the RTMS. And white matter, sometimes they talking about hyper-connected, but more important is not concerted activity. Just like we walk to dinner, doesn't matter how slow, how fast we walk to the dinner restaurant, but the most disruptive way would be we have a different speed. All those group people have different speed. So this really reflects white matter traffic. So widespread loss of white matter integrity and reported white matter tracks involved would be important. White matter abnormalities, different ways, oligodendrocytogenesis integrity. So white matter integrity essential for neural communication, disrupted in some disorders, well documented, serve as a biomarker for early detection and treatment response monitoring. So those therapeutic intervention strategies, especially with the drug trials, drug design. And we all know white matter in psychiatric disorder may be due to demyelination or partially demyelination, dysregulation, dysregulation. Yeah. And also you can see all those matters, factors, regulators, so much work, so many people published, but how to consolidate to clinical picture. That will be a daunting task. Okay, let's come back to a clinical picture as clinicians to say it. White matter change in schizophrenia and really contribute to, some people argue about negative symptoms, contribute to cognitive deficit, impact outcome, treatment response, and early detection, intervention would be crucial. So that's why many psychiatry medication can produce immediately transmitter receptor changes, but need time, at least a few weeks to see the consistent impact may be related to white matter function adjustment. So neurodevelopment disorder and white matter, so I use neuro rather than neuronal. They call neurodevelopment disorders, white matter, autism, ADHD, and others related to Asperger's, social communication, executive functioning, cognitive disability, with all those relevant to white matter. So white matter still matter and very matter. White matter change in mood disorder, also a lot of publication white matter in major depression, structure change to neurobiology depression beyond BDNF, and also different regions indicated in depression. Certainly, almost all mental disorder have a networking problem, not necessarily pinpoint to particular nuclear. Even Parkinson's disease, we could not focus on only substantial nigra nowadays. So neuroplasticity in depression, also another treatment window, and it's a concept or approach. So brain is very dynamic symptoms, neuroplasticity equal to adaptation to external or internal stimuli, neuroplasticity, and maintenance of structural plasticity will be impaired. Change in concentration of neurotransmitters, just like we even argue more episodes of bipolar manic, we have a more permanent brain damage. Maybe neurotransmitter flood, or seizures, and receptor activities, also important. Synaptic cascade. Talking synaptic cascade, we always thinking neurotransmitter and receptors. Actually, synaptic cascade would or will involve with white matter as well. We know the psychotherapy for depression with all those schools approach. Where's the target? We got a CBT, IPD, where's the target? Do you think it's a networking adjustment? And networking adjustment will influence the traffic. And where's the traffic? It will be white matter tracks. And also recent ECT is old. But nowadays, magnetic, vagus nerve, current, direct current stimulation, brain stimulation, right now also have alternative stimulations. And we also have unconventional or complementary alternative medicine, yoga, exercise, and some herb. So all those approach, where's the target? And certainly we know antidepressant would be all the approach we choose first. We are physicians. And then there's a good response would be around, first trial would be around 60%, but 40% would classify as placebo. Actually, placebo is not placebo. If the medication was given by physician or nurse, that's also indication of treatment. If the medication gave in the coffee wandering machine, that would be different. So they talk about 40% placebo, I would say, is the billing of a psychiatry or psychologist. So it's not real placebo. So I will present some data talking about treatment enhancement oligodendrocyte in depression and Prozac imipramine reverse losses. ECT increased oligodendrocyte 2, NG2 positive glial cells, And environmental enrichment also stimulate oligonucleotide progenitor cells. So all those with multiple references and report over the many years. So here is some research we did in our lab a few years, many years ago. Amitriptyline, fluoxetine, venlafaxine all upgrade the mRNA of ISOD and counteract of damaging effect of hydrogen peroxide in salt. This is a cell culture part. And here is another kind of a neocortical cell culture. It's got a small ball of the brain with all those structures involved with axons, receptor formation. So we use quetiapine to treat the culture. And you can see the relative density and treated by quetiapine will survive much better. And also the myelin structure is way better than the non-treatment group. So quetiapine enhance the neocortical cell formation. We also use an animal model, you can see, with antidepressant and use the venlafaxine, really enhance the hippocampal neuronal structure and so-called neurogenesis. So here's 3 weeks of treatment and 2 weeks of treatment with venlafaxine. That's the treatment. Actually, when we talk treatment, actually it's not treatment, it's a prevention sometime for the insult. Here we look at the diminution in 2 phases. One phase is prevention, another phase is after the damage is done and with the treatment. So here we use the small animal, the MRI to look at the diminution process. And quetiapine and the cupsone, you can see the cupsone is neurotoxin deliberately destroy white matter, and a very old model. And we use quetiapine. The neuronal damage is much less. This is actually prevention because we gave quetiapine same time with the cupsone. And with the pathology, you can see here, cupsone have diminution, but we also have quite a filtration of glial cells, some microglia cells there, so must be some neural or cytokines involvement. And we also have quetiapine-induced diminution, and also after that, we give quetiapine and then really see the recovery, much speed up remediation process. We also try something in different approach, just like see many things working in the, just like aspirin. It's old thing, but with a new story. So here is Rika cashew. And we all know there's probably 1 billion people in the world use arena capsule, especially in Taiwan, right? So antidepressant effect, anti-inflammation effect, antioxidant effect. And many trackers are chewing those, keep them alert. And there's a report called anti-schizophrenia effect, especially in India. Some literature report that. And memory protective, certainly cause oral cancer, but I'm not sure about prevention of Alzheimer's. So we use the animal model to do and modulate white matter integrity. And then treatment response, look at the progress and long-term outcome, and monitor the medication interactions and try to optimize the treatment. So that's the purpose in our practice. So another part, we also look at the white matter response under the treatment of magnetic stimulation, similar like so-called RTMS. Try to restoring the so-called hypoactive brain. But in reality, we are not sure about the frequency and so-called stimulating or inhibitive. That's all wishful thinking in our clinic. In reality, a patient responds better, and we have to figure out how to explain it. So here you see with the magnetic stimulation with animals, and look at the social interactions, look at the demyelination process with the magnetic. And also we recently, actually a few years ago, have a student look at the low intensity pulse ultrasound LIPERS device. And what we do, you see ultrasound is another stimulation in addition to magnetic, electric. So we look at unique LIPER intensity and look at the different frequency with the cell culture and then later on with animal models. And here's the parameters. And we collaborate with Dr. Chen in Universal Laboratory in the computer engineering. Yeah. So here's some potential mechanism. Basically, it's ultrasound is a sound, and then we say it's a massage to the membrane and to the cellular microstructure, and that's the ultrasound. And then you see here is an animal we put in the tube, immobilize, and then some shape treatment, some real treatment, and see what kind of change or reverse the treatment. You can see here's a Saccharose preference test. We all use those reflect the anhedonia, the depression. So here we can see the ultrasound really reverse some of those behavior changes. And also tail suspension test, Y-maze test, and then we also look at some so-called biomarkers or the molecules markers. So the result was LIPERS ultrasound prevent injury to myelin and oligodendrocyte and increase BDNF, and also the lessened or attenuate depression-like behavior with those ultrasound. So the ultrasound might be therapeutic target. Actually, in clinical, right now there's ultrasound machine already to treat depression, similar like RTMS. So to summarize, with those interventions, so medications, RTMS, and ultrasound increase oligodendrocyte, reduce astrocyte, prevents demyelination caused by cupsome, that's a neurotoxin specific, and prevents behavior impairment, and oligodendrocyte genesis, such like cell culture, animal model markers, as a potential target in the treatment of major depression or beyond. So what's we're thinking about clinically? So we should try integrate white matter biomarkers in other markers. Diagnostic accuracy, hopefully will be useful. Treatment efficacy, patient outcome, and future research should focus longitudinal studies, treatment response monitoring, and precision medicine should include white matter change, not only neuroimaging, hopefully some peripheral markers will be useful in addition to those cytokines, receptors, and now early days we look at platelets. So here's the some of my collaborators, Jimin Kang, he's here in this conference, and Yanbei Zhang, he's here in this conference. And also some funding agencies over the years for myself and for my student. And also Dr. Xiaoyang Bi, she's a neurologist. She's here in the conference as well. So I will stop here and just want to raise some notion, white matter sometimes may be more important. The gas station important, but highway also important. Thank you.